Thank you. Good evening, everyone. And always a hard act to follow Mohan, but I will try my best. Um, so, the topic that was given to me is fat mass and fat free mass and offspring of mothers with GDM. So, I actually wrote to Dr. Sabu and said that's a very like small area of this whole thing, and I'll try to cover a little bit more of offspring of mothers with GDM and diabetes actually. Just to set the stage, as you can see, the amount of gestational diabetes globally and especially in our part of the world is something unimaginably high. We are somewhere in the, globally, it's somewhere in the 20 to 23 million women are having a GDM per year. So if you think about it, in just 5 years, 100 million women develop GDM. So that's a very big number. And in India, it's expected we had about 29 million babies born last year. And even if you say that 15% of women who are pregnant had GDM, we're talking about several millions of mothers and babies born to mothers with GDM. So this is a very busy looking slide. And I just want to, when you look at the left panel, the number of things that can cause GDM is listed. But if you look on the other side, one of the important things that I want to point out is, what can happen to the baby. And one of the very important things that can happen to baby is actually the large for gestational age and also babies who are born with, macrosomia. And when you take diabetes itself, you can also have small for gestational age babies, depending upon if it is type 1 or long duration type 2, or if it is a mother who is also has some nutritional deprivation during the time of pregnancy. And just want to show you that the obesity epidemic in children in India is also tremendously on the rise. And if you see here, it is now expected that 1 in 10 obese children globally will be from India by 2030. So on the one hand, we have a rising, epidemic of GDM, which can lead to large babies and macrosomia. And on the other hand, we are having this rising epidemic of childhood obesity. So obviously, one is contributing to the other in a big way. We know about the consequences of GDM to the offspring. Obesity is a very, very big one. Of course, pre-diabetes and diabetes to the children. This is all to the children, by the way. Neurodevelopmental issues from ADHD, autism spectrum disorders, learning disabilities, and all of these have been now linked to maternal obesity also. And then gestational diabetes can also cause, can in the mother can cause gestational diabetes in the female offspring, and high birth weight can lead to birth injuries, neonatal hypoglycemia, respiratory distress syndrome, COPD, and in cardiovascular disease, fully completing the complement of NCDs, which is why GDM is now called the mother of NCDs. Okay. And from the HAPO follow-up study, just to show GDM association with childhood anthropometric outcomes under full model adjustment, including maternal BMI during pregnancy. And you can see overweight and obesity, significant obesity, and then percentage of body fat that is more than 85th percentile. All of this, as you can see, very, very significantly elevated in infants born to mothers. And this is an older study which again clearly showed us risk of overweight and abdominal obesity at an older age, at age 16. So you can have it at birth, you can have it during infancy, you can have it in childhood, and you can actually also, they've shown at the age of 16, prenatal exposure to maternal pre-pregnancy overweight and gestational diabetes. In this particular study, this is from the US, which shows risk of adverse outcomes associated with obesity. One of the very important things that they've shown is macrosomia and large for gestational age that happens with maternal obesity. And why we cannot completely separate maternal obesity from GDM, big chunk of women with GDM are obese. as much as 50% or more are obese. And also, you can see that if the mother is obese, there's a greater risk of gestational diabetes also. So then it becomes a double whammy. What happens in India? This is a study from South India, which showed when there was maternal obesity, the same thing, hypertensive disorders of pregnancy, gestational diabetes, which I've outlined here. This has been shown, very nicely. It's also showing that there is a increase in the newborn weight and increased risk of operative deliveries. And let me show you another slide. Um, okay. What happens to the baby now? We'll go focus on the baby. So we've typically always been thinking about either the baby is too small or too big when there is a diabetic pregnancy. Typically, when mothers are having type 1 or long-standing diabetes, they usually have what's called as placental syndromes. They have vascular insufficiency at the level of the placenta, and the baby ends up being maybe small. But in with GDM and in mothers with type 2 diabetes or maternal obesity, more often we end up seeing the big babies. So, this very interesting review, it says an unwelcome inheritance, childhood obesity after diabetes in pregnancy. An excellent review, which I would encourage all of you to read, very recent one. So, this talks about, okay, worldwide, 23 million babies per year, as I mentioned, are born to mothers with diabetes. Exposure to maternal diabetes in utero is associated with 2 to 3 times increased risk of overweight or obesity in young children, 3 to 4 times increased risk of obesity or glucose intolerance in older children, and then this risk continues throughout the life. But then what happens is, they very clearly explain to you what are the contributing factors. If you see here, maternal glucose, maternal BMI, preconception, maternal diet and exercise, and paternal diet and exercise, and paternal diabetes also, have a contributing thing. When it comes to pregnancy, the contributing factors become maternal hyperglycemia again, now maternal lipid homeostasis also, fetal hyperinsulinism, offspring size at birth, and offspring insulin resistance, and maternal diet. And it's also been shown that mothers who have gestational diabetes have higher fat content in the breast milk and lower protein. So that has also been, contributing to the obesity in the infancy and postnatal, as you can see. So a lot of this comes back to maternal diet, maternal obesity, maternal hyperglycemia. So towards the end of the talk, what I want to talk about is potentially what solutions can we arrive at. And this again hypothesis on how does all this develop, the effect of maternal diabetes upon childhood obesity, partially mediated through altered lipid metabolism and distribution and increased offspring pancreatic function from birth. So if you look at the genetic factors, maternal insulin if you look at maternal insulin resistance, beta cell dysfunction, autoimmunity, then that leads to maternal hyperglycemia, that leads to some altered lipid metabolism. Then all of this then goes and has influence on the developing fetus, and then of course this continues into adulthood. So very, very important to keep in mind that all of this kind of boils down to the hyperglycemia, the obesity, and dyslipidemia. And I'll show later about dysbiosis and other emerging factors in this. Then the Pedersen hypothesis. Pedersen hypothesis was, kind of a simplistic. Mother has high glucose, it goes across to the baby, fetal hyperglycemia. The fetus makes a lot of insulin, so fetal hyperinsulinemia. And insulin is anabolic, and the baby is going to grow fat. So this was the oversimplified explanation from the Pedersen hypothesis. But if you just drill it down a little bit, you can see the Pedersen hypothesis is a little more nuanced than that. If you see here on this side, ethnicity, physical inactivity, obesity, dietary composition, PCOS, and other things. And now we can add endocrine disrupting chemicals, air pollution, and many other things, will lead to the insulin resistance, which will lead to the high glucose levels, which will then go across the placenta to the baby. And then you can see the pancreatic production of insulin from a simplified thing. But also, there are other things like placental hormone production, which I'll show you in the next slide. So it's not actually that simple. There's higher IGF-1, higher leptin levels, lower adiponectin levels, lower ghrelin levels, increased TNF. So inflammatory markers are also going up, and of course the pregnancy related hormones. So all of these are all counter regulatory hormones. All of these are going to work against any kind of insulin that the mother may have, which ultimately will lead to the hyperglycemia. And then there are also placental factors that are being produced. And then when it comes to the fetal factors, look here, there are also other hormones that are being produced. Here also, C peptide, and then you can see adiponectin, ghrelin, all of those things are changing. So ultimately leading to fetal growth and neonatal macrosomia. So it's not just a simple glucose going, insulin being made more, baby getting fat, but actually it's very layered and nuanced than that. Also, the placenta itself acts as a nutrient sensor. The placenta integrates maternal and fetal nutritional cues, takes the information, and through regulation of nutrient sensing pathways, will attempt to match the fetal demand and maternal supply. So, to support this model, maternal obesity is actually associated with increased. The placenta expresses more of the system A amino acid transporters and things like that. Now, there's one more new concept that I want to introduce, which is the exosome vehicles that actually seem to work. So, excess nutrients are transferred to the fetus in GDM. Possibly also these exosomes are also at play. Now, what about gut microbiomes? I mean, without gut microbiome, there is no topic. So you can see here, maternal health, especially things like gestational diabetes or obesity, will lead to maternal dysbiosis. And then there is altered small chain fatty acids, more inflammatory markers. All of these things will lead to higher lipopolysaccharides and change the fetal gut microbiome, fetal dysbiosis. If the baby is big, there's chances it'll be born by cesarean section. And we all know when there is no vaginal delivery, the baby doesn't swallow the mother's vaginal fluid. So the gut microbiota is altered by that also. And breast milk is different. So here you have on the one hand, mother's gut dysbiosis, increased risk of C-section deliveries, and also altered breast milk composition. All of this can lead to fetal dysbiosis and increased obesity. And now the newer endocrine disrupting chemicals, everyday chemicals that we are using, everything from cleaning agents to pesticides to cosmetics to all sorts of things. And of course, the bigger endocrine disrupting chemicals in plastics and other things also causes an obesogenic environment. Obesogenic environment at the level of the mother, causing, in mothers with gestational diabetes and in mothers, leading to obesity in the baby. So, all of this explains why obesity may be happening. Our own Pune maternal cohort done by Dr. Yajnik, and it's been like 30 years since they've been doing, and though they have not measured the fat mass or the fat-free mass, they've done it for the mother. But for we're talking about for the babies, they've also shown that the fat mass goes up in even in the mothers with the gestational diabetes. But an excellent paper just came out in 2025 from Pat Catalano and others that shows infant body composition trajectories differ by in utero exposure to gestational diabetes. And this is a prospective cohort from birth to 12 months. Very important paper because, one of the first times they've shown, I'll show you. So the characteristics of mothers and infants included in this sample, like you can see here, the BMIs are The BMI is much higher in the mothers who have gestational diabetes. And the gestational weight gain is actually a tad bit less in the GDM moms because they've been on a stricter diet. So it's not the weight gain. So obviously, it is the underlying all those things that I talked about so far. And I'll show you in the next slide what happens to the baby. And you look at the fat mass at birth and the fat-free mass at birth, and also you can see the BMI at birth. BMI is not very significantly different. They are large for gestational age, but they have more of the fat mass. So in this cohort, what they showed was infants exposed to GDM in utero had higher mean fat mass, BMI slightly higher, and percentage body fat at birth, but lower mean fat mass and percent body with fat gain over the first year of life. This may be what we call a catch down phenomenon. So sometimes babies that grow fast, they'll have a catch down after they come out. It may be a phenomenon like that, and or it may be this in utero exposure, and that is the imprinting that goes on, and greater adiposity at birth. So very important study for us to follow. And then in this study called as the gestational diabetes and size at birth, they modify early adiposity accretion. This is the obeso cohort. And in this particular study, what they found was, I'll show you. If you see here, this is the fat-free mass, and at 6 months of age, babies born to mothers with GDM, they had accrued more fat mass. So this imprinting is happening very early, and that is what we need to be very, very watchful about. I'm coming to the end of my presentation, and now I want to focus on what can we do about this. So first thing is to know that maternal obesity has myriad manifestations, from pregnancy and delivery complications, everything from subfertility to causing GDM, to long-term outcomes for the mother, which includes type 2 diabetes, cardiovascular disease, hypertension, stroke. Then you look at fetal outcomes. One of the things we always thought was it's either big baby or small baby, but we now know that congenital heart disease, congenital, abnormalities, birth defects are more in babies born to mothers or simply they don't have to have GDM just on the basis of obesity. If they also have GDM, then it becomes amplified. So congenital malformations, macrosomia, large for gestational age. And in the long term, these babies are also having, long-term complications just like the mothers. So this is a very busy slide, but this is almost my concluding slide to say that these are the risk factors for GDM. So we've always known about metabolic syndrome and obesity and pre-diabetes, sedentary lifestyle, unhealthy eating, advanced maternal age, pregnancy itself, multiparities, prior GDM, um, if the maternal low birth weight, if the mother was born small, she's at greater risk for future GDM, Barker hypothesis, or a previous big baby, family history like a maternal GDM, ethnicity, social determinants of health. But I want to say that, and PCOS, of course, what is now emerging are these guys, things like air pollution, gut microbiome, mental health, social determinants of health. All of these things are emerging, thyroid deficiency, possibly vitamin D deficiency, are emerging as risk factors for GDM. So if we want to prevent childhood obesity, we need to address these risk factors. We need to address the risk factors, what makes the mother overweight. Only then we can actually, because I showed you, it is not the weight gain in the pregnancy. It is what they start with and the hyperglycemia itself. And so we've come a full circle to Barker hypothesis, which is the developmental origin of health and disease. And we really want to, start very early And we would have all heard Dr. Mohan talk about, early GDM. So we got to screen them at first booking as soon as they come. And then if they are normal, then you want to screen them again 24 to 28 weeks. If they are normal, then, and if they have risk factors, screen them again later, 6 weeks. But most important, I think we need to go to before she gets pregnant. We want to optimize the health of our women. Thank you so much.